warm welcome on behalf of Pratima Hospitals and IAP of Varangal branch. So this session purely handed over to Dr. Karunakar for remaining session and also.
Welcome to seniors and the speaker, Dr. Madhusudhan sir. We are very happy, sir, for having CME with you, sir. A small CV regarding Madhusudhan sir. Sir is MS MCH from AIMS and FRCS from the EDIN. Sir is professor of Department of Gastroenterology and head of the department, Usmania Medical College. And sir did MBBS from the KMC Kaktiya Medical College. That is the reason why he is happy to come here, and we are also happy, sir. MS from the Usmania Medical College and MCH from the AIMS Delhi, and liver transplantation from the Pittsburgh, US, and the visiting scholar in Tokyo, Toronto, and Japan. Sir received many awards and achievements. Among them, one of the best is Best Doctor Award from the Chief Minister of Telangana from 2017. Sir did first liver transplant surgery in a government sector in Usmania Medical College. We are happy for that, sir, for poor patients. And sir did first auto liver transplantation in India, second in the world for chronic Budd-Chiari syndrome. And sir also established the organ transplantation surgeries. And sir did first pancreas and kidney transplantation, got excellence in the gastroenterology award from the IMA Meditech, conducted many organ donation public awareness programs in colleges, schools, and various hospitals. It did very rare surgery, first time in India, that is left splenorenal artery anastomosis and mesenteric renal arterial anastomosis in 2 stages. Specialization area of interest is liver transplantation, both cadaver and living donor, and pediatric liver transplantation. Sir did 42 pediatric LDLT till now, and split liver transplantation, combined liver and kidney transplantation, simultaneous pancreas and kidney transplantation in diabetic kidney failure patients, and multi-organ transplantation, complex liver rejection for pediatric liver cancers, that is hepatoblastoma, and experience in ALPPS procedures and various surgeries. Sir has so many memberships, so many publications and presentations. With this, I will invite Madhusudhan sir for the CME on behalf of IAP Varangal branch. We welcome sir and thank you.
Good evening, respected senior faculty and IAP Varangal chapter for giving me this opportunity. Thank you very much. President Dr. Ashok Reddy sir and Secretary Dr. Karunakar, Dr. Mohan, Treasurer, and senior dignitaries. I have seen, after 20 years, I have seen so many, Dr. Narahari, Dr. Ramesh sir. These are all our teachers when we are doing it, MBBS medicine that time. Thank you very much, sir, for coming. Basically, why liver transplant? It's not for commercial leaching or any other things, because during medicine time, we used to see all chronic liver disease, whether it is in medical ward, whether it is in pediatric ward, all CLD patients, we used to do only conservative treatment. As you know, they used to land in repeated hospitalization, abdominal paracentesis, or if it is refractory GI bleed, blood transfusion, or one step ahead is giving endotherapy like EST or EVL banding in adults. Like encephalopathy, you make it purgate with the Diflax syrup, anti-coma regimens. But I'm sure as a senior colleagues, you are practicing more than 20 years, you have seen. You are not going to change his life. So you are just changing the mode of death. So if you treat with a refractory ascites, with paracentesis or diuretics, he may land into hepatorenal syndrome. If you try with that, he may develop GI bleed. So you are not curing the patient, you are changing the mode of presentation, mode of death. So if you treat refractory ascites, he die of hepatorenal. If he die of hepatorenal, he will die of SBP, or he may develop of liver cancer. Like that, vicious cycle is going on. So you are not treating the root cause. Only some conditions like where you can detect early, like Wilson's disease, you have a good drugs. You have a autoimmune liver diseases. If you are in early stage of cirrhosis, you can stop by giving a steroid. Or hepatitis B, you got a good drugs. And last 5 years, hepatitis C. Previously, you used to have a drugs like only indirect therapy, gamma interferons, all these things. Now, direct acting antiviral drugs, sofosbuvir. These are the things that have changed the game. So some of the conditions still needs liver transplant. As you know, acute fulminant liver failure. I'm not saying that all acute fulminant liver failures need transplant, but some of the condition you must have seen in your best of intensive care management. You have taken care of intracerebral pressure, you have taken care of coagulopathy, good intensivist, ICU care. Still, some patients are, in spite of doing, going and rapidly deteriorating. One organ failure to multi organ failure, parents, everybody will be so much of pressure on you. And naturally, young fellow, which doesn't have a previous any existing disease, is dying. So that time you will realize, is there any option? Is there any options? People have tried plasma exchange, then biological liver support agents like MARS, some hepatocyte transfusion. Everybody's tried, but still mortality is occurring. So these are the areas we would like to cover. What is how much advances is going on. So most important thing, because when I finished my liver transplant fellowship after doing MCH from All India Institute, because India not much of training for the liver transplant during my MCS PG time, because I finished in 2007. During that time, liver transplant was only confined to 2 centers. One is in Delhi, another is in the South Global. The team used to come from only King's College London, flying and going. So during that time, we realized that India needs more, but not adequate training centers were there. So during that time, that Medicity, one of the our senior faculty, and he was also from KMC. So Dr. Reddy sir helped me to get a fellowship there. So I joined in Stargell Transplant Center, Pittsburgh. Stargell is nothing but he was the father of liver transplant, who first invented the liver transplant program. He's invented cyclosporin, anti-immunosuppressant drug, and he did a maximum number of liver transplant for congenital biliary atresia. So when I joined, he was retired but emeritus professor. He was staying in the campus only. So he was nostalgic teaching. Coming to my topic, just I shortly bring down. So liver transplantation is a definite life-saving procedure for acute fulminant liver failure in some cases where, in spite of your medical management, 20% of the patients need life-saving measures. Another thing is sometimes unresectable primary liver cancers, especially hepatoblastoma, pretext 3 or pretext 4. That means if it is occupying all segments of the liver, or if it is central portion involving the major vessels, you always give a adjuvant chemotherapy because hepatoblastoma is highly chemosensitive. Some cases downstage occurs, then after that we do resection. Some cases, in spite of your giving first line chemotherapy, second line chemotherapy, still it is confined. In such cases, this is the only definitive life-saving procedures. Another important thing is a definitive therapy for a decompensated chronic liver disease is a liver transplantation. And people are asking, this liver transplantation is just fascinating, how long he will survive. Even if he survives also, his quality of life worst. He has to be lifelong dependent on family members. He won't have a good quality of life. No, the people have published enough number of articles on long-term survival rate, long-term overall survival, long-term graft survival rate, as well as quality of life, not only from American Association, European Association, Indian Association, and I have my experience because I was practicing for almost 15 years. My own patient is still living 10 years following a biliary atresia liver transplant, because recently only we did a World Liver Day, so he invited that boy to come. So thing is, initially we used to calculate 5-year survival rate. 5-year survival was almost around 80 plus. Now after that 10-year survival, then also it is become still in 80 percentage. Even 20-year survival rate is also there. One of the patient during uh, when we were in the AIMS Delhi during that time, Gangaram team did it one liver transplantation for pediatric biliary atresia. I was assisted for them because in a resident fellowship rotation will be there. So that boy now became a MBBS doctor. So the quality of life will not be compromised. Then coming to the what are the liver where it comes. So usually all over the world, predominantly, especially European community and North American community, it's predominantly cadaver breed. So whenever there is a brain death, not a circulatory death, it's a brain death. That means patient brain is irreversibly damaged, no brainstem reflex, but BP, heart, lungs, everything is functioning, but is on ventilatory dependent. So no respiratory phenomena, no gag reflex. Such patients, if the family members are willing, then we can take organs. The problem is pediatric brain dead donors is very scarce, not only in India, everywhere. As you know, because pediatrics, especially children who has sustained head injury because of fall from the roof or sustained road accidents, family members little bit of more stressed up, and if you ask them also, they may react virulently. So that is why even in Jivandan, if you statistics, if you take also, almost less than single digit, yeah, 4 or 5. That too, their family members only came forward. It's not by we asking or anybody. So what to do if the adult brain dead donor is, if you available, that liver may not fit into the child because abdomen is small. That so there new methods came. Split living. Splitting means left lateral segment, left of falciform will be given to the child and right lobe will be given to the adult. So that way gradually expanding for the pediatric patients, because majority of the time pediatric patient waiting, but no organ supply and they're dying. So that is why split liver transplant came. After that, then living donor transplant. Then after that, so many ways I will show you that. So why this split or living donor transplant works is, one fundamental principle is liver is the only organ in human body which can regenerate. So even though it's a single organ, functionally it divides into the right and left lobe because of blood circulation, bile duct distribution. So if suppose I am the donor for my child, if I give a left lateral segment, whatever the amount of liver I have given, that will regenerate in 6 weeks to 6 months. Same of liver, if I implanted in a baby or adult, that liver also will go. So how much should grow means 2% of the body weight is our liver volume. That means 70 kg fellow will have 1500 grams. So even if you implant 600 grams in adult to adult, that 600 will multiply till his body weight 2%. Same thing like that. So this is the principle we are utilizing for a living donor liver transplant or in a split liver transplant. What is why kidney transplant you are seeing last 30 years nobody is surviving this many years not doing a good quality of life. What made liver made a good quality of life is, out of all organ transplant, if you take a liver, pancreas, small intestine, kidney, liver, the liver transplantation needs least immunosuppression. The reason is HLA type 2 antigen expression on hepatocyte is very least. Wherever HLA type 2 antigen is least, rejection is less. So that is why what we do is, after 6 months, we decrease immunosuppression so less that patient will not have a immunosuppression related complications like infections or kidney toxicity, etc. So that is why wherever there is immunosuppression is less, patient will have a good quality. Whereas kidney you can't do it. Worst thing, that is why even if you take, I am a intestinal transplant, pancreas transplant, but that is not going that much successful mainly because intestinal transplant need 4 immunosuppression. Out of all organ transplant, 4 immunosuppressions because of gut associated pair patches, lymphatic tissue will throw so much of immunological rejections. So that is why intestinal transplant is surgically easy, but long-term survival and quality of life is less. Whereas in liver transplant, surgery is very difficult because you need to remove diseased liver in the background of portal hypertension, coagulopathy, and you need to put in another liver. So surgically is very difficult, but if they survive up to first 1 month, they do very well compared to other organs. See, you see it's such patients. This is a neglected biliary atresia presented with a full-blown decompensated cirrhosis ascites. Whatever the method you give, either ascites, TAP, either you do, you won't give a good quality of life or you won't expect survival not more than 2 or 3 years. But we did a transplant such baby, you see that this is a hepatoblastoma, CT, entire liver is occupied with tumor. We do transplant after a good chemotherapy. So that is why it is a definitive trend. You see that it changes the quality of life also. This child, see, fully decompensated, bedridden to the hospital after doing a transplant, very nicely playing. This is the one nostalgic photograph I am sharing everywhere to convince our fellow colleagues about how liver transplant changes life. This is the when I am doing a fellowship at Pittsburgh. This guy came to OPD clinics during the Christmas seasons. So this guy looking more healthier than me. Actually, this guy underwent a liver transplant for biliary atresia at the age of 6 years by Professor Stargell. So he came, that time he was 25 years. So I just asked, what is your occupation? He's a rugby football player. I can't play even rugby football. It needs lot of stamina. So what I mean to convey message is, liver transplantation fellows will have a good quality of life as like regular fellows. And good quality and longevity. You see, 6 years child and becoming 25 years, almost 20 years. So it is a life-saving procedure. It is a long-term good quality of life. The problem with the adult and pediatric liver transplantation is, in pediatric transplantation, baby has to grow with the liver. That is the big problem. Because as you know, all immunosuppression drugs, whether steroids or tacrolimus or cyclosporine or mycophenolate, that is anti-metabolic, which causes some amount of growth disturbances. So in adult, I did a transplant. I just bothered about whether rejection or infection and titrate the immunosuppression increasing, decreasing, and you will be settled over a period of time, 1-2 months, as like diabetes drugs, hypertension. Some require 2, some require 3, like that. We will adjust, then you will stable. Whereas in a child, you need to follow them lifelong because they have to grow. I did a transplant for 4 months baby. I need not only survival, I need to, baby should grow, baby milestone should grow. So that is the big problem. Growing up with the liver transplant is different from being transplanted in adult. So what we do, what are the changes? So now people are started weaning off the immunosuppression. After 5 years, if they don't develop rejections, or we use a tacrolimus very minimal dose, like 1 milligram twice a week, only one drug, Monday and Wednesday, or Wednesday, Saturday, Sunday, like that. So after 5 years, we are weaning up. That way we are helping baby is matching with that and grow with the normal. So this is the world over. In a pediatric liver transplant, the indications we classify like jaundice type, cholestatic type liver diseases, or metabolic liver disease, or enzymatic deficiency diseases, or liver failure type, hepatocellular, like acute viral hepatitis, chronic viral hepatitis, autoimmune viral hepatitis. Sometimes we do a transplant for tumors which are unresectable, like hepatoblastoma, pediatric hepatocellular carcinomas, like that. So out of all these are the diseases are more predominant because commonly we get a referral for such patients. So in that biliary atresia is very common, 34%, because majority of the problem in India is diagnosing late or coming to the late. So Kasai is a good operation if you do before 8 weeks. But majority of the time they come very late or late diagnosis. By the time you open for that, liver becomes cirrhotic or hard and close it. Or sometimes failure of Kasai is very common. So which patient you need to do a transplant in biliary atresia, because I have given enough number of time lecture for our pediatric surgery postgraduates, so I will share that. So next one is we see Alagili syndrome. This is a quite reverse. In extrahepatic biliary atresia is extrahepatic bile ducts were atresia, not development. Whereas in Alagili syndrome, intrahepatic bile ducts, hypoplasia of the intrahepatic bile ducts, whereas extrahepatic bile ducts may be normal. So like that, PFIC, because of increasing the awareness of cholestatic liver disease mechanism, because of diagnostic facilities increasing, we are seeing very frequently PFIC, that means progressive familial intrahepatic cholestasis, where patient will have a cholestatic. These are all will have an conjugated hyperbilirubinemia. Jaundice will be there, itching will be there, all will present like that. So how to differentiate PFIC is, PFIC fellows, ductal system normal. Both intrahepatic ductal system normal, extrahepatic biliary ductal system normal. If you do ultrasound, liver, no obstructive element at all. So how to diagnose? If you see that LFT with GGT, gamma glutamyl transferase, even though jaundice is 12, direct bilirubin is 18, like that, alkaline phosphatase is elevated, but they will GGT will be normal, gamma glutamine transferase, or low. Then you should have some suspicion. So this could be a PFIC. So that time we need to do a biopsy or we need to do the genetic testing. Then you can make it that PFIC. Why important is PFIC if you detect before onset of cirrhosis. As a physician, you can treat with high dose of ursodeoxycholic acid. It can stop the progressing into the liver disease. Or if you detect some more early stage, you can do non-transplant procedures like external biliary diversion or ileal exclusion. That nothing but in PFIC what will happen is bile salt export mechanism is defective. So if you encourage more bile salt loss, enterohepatic circulation, as you know, all bile salts will be absorbed in the right iliac, that is ileocecal junction and cecum area. If you exclude that area, so bile salts will loss in the stool, so that gradually every day 10%, 10%, so patient accumulated bile salts will go in the stool, so his itching will come down, jaundice will come. That is the principle. So if they come in too late in advanced cirrhosis, you need to do a transplant. So like that, we make it. So what is the exact indication? Because many times physicians ask me, tell me, what is the real indication for a liver transplant in a diagnosed case of chronic liver disease? Now and every time I insist that child A cirrhosis doesn't need any liver transplant, because any procedure if you do, risk versus benefit ratio is important. By doing a more harm or you are doing a justice. So there is a way of calculating disease severity score. Like in adult, model for end stage liver disease called MELD score. Whereas in pediatric below 12 years, we use pediatric end stage liver disease score. This is available calculators in any net, any cell phone also. What the parameters they select, bilirubin level, they select albumin levels, they select INR, then you need to add age and growth retardation is there. If you add these parameters, you will get a score. So PEL score more than 16 means this patient need a liver transplant. Why? Because they have observed natural history of all MELD score, PELD score fellows. By 16 or more, if you wait for 1 year, 30% will die. If you wait for 2 years, 60%. Majority of the patients will die by 3 years. So whatever the treatment you do, varicose bleeding, ligated, etc. So you will change the mode of death, but you are not preventing the death. So that is why you need to do, you need to refer the such child for a transplantation facility center. So there is another simple way. If you don't have this calculator, all this simple way, child score also. So child B and C fellows usually needs liver transplantation 1 day. Or other way, simple way is refractory GI bleed, refractory ascites, refractory SBP, recurrent encephalopathy. Like that, these are the definitive established indications for a liver transplantation in a case of chronic liver disease, whatever the etiology. So coming to the biliary atresia, when you have done a Kasai enterostomy, whether it is successful or not, there are evidence-based literature. International Pediatric Study Group on Liver Disease clearly mentioned, after reviewing the so many articles, they says that after 3 years, if the bilirubin, after 3 months of 3 months of your enterostomy, child's bilirubin below 2 means, that means they are successful and they 80% will live up to 10, 15 years also without any liver transplant. Native liver make it. If the bilirubin is above 6, means they will not survive. So that patients, so that is why they mentioned that 84%, so 16%. So if it is more than 6 bilirubin, after 3 months of post Kasai, 16% only survival. So all will die. That means about 80%. So your surgery is not successful in such cases. You need to refer. Some of the cases are there between 2 to 6. What to do? So such patients also need to be close follow up with the transplant team, because these patients will land some patients recurrent cholangitis, recurrent infection, recurrent bleed, recurrent ascites, severe itching, quality of life compromise, not going school, frequent hospitalization. Such patients also, case to case basis, we need to reassess. And most important thing, by adding a steroids, there is no way evidence proves that it decreases the jaundice or anything. Previously, we used to thought that prednisolone adding it decreases, but it is not going to give it. So these are the evidence based in biliary atresia. So in biliary atresia, before Kasai, late presentation is also definitive indication, because after 8 to 10 weeks, if they come, usually liver get a heart cirrhosis. So such patient doing a enterostomy no meaning, because that's invariably going to be futile and failure. This mother is the donor, child is autoimmune cirrhosis with decompensated. This is a Wilson's disease child. This is congenital hepatic fibrosis, like that. So this is the child after 10 years of follow-up of biliary atresia growing normally. So this is congenital hepatic fibrosis. This is a hepatoblastoma child in spite of two regimens of chemotherapy. So patient did not respond, so we did a transplant like this. So this reduce, I already told, even left lateral segment sometimes bigger for the small babies. So we need to reduce. So this is a segmental anatomy base. So this is the child biliary atresia with full-blown decompensation with ascites, umbilical hernia, grass cirrhosis, less than 6 kg. So even mother's left lateral segment appears to be big. Otherwise, compartment syndrome will occur. If you stuff big volume of the graft, you cannot close the abdomen. Compartment syndrome. So we need to reduce that. So we have reduced in both. So reduce size graft. Happy to share that baby came after 1 year, so first birthday. So both are happy. So this is the science is our. So sometimes mother's blood group may not match, father's blood group may not match. You need to depend on cadaver. But pediatric cadaver donors very scarce. So adult cadavers sometimes we can utilize for the pediatric also. How we split, if the one cadaver available, we split into the, so right lobe we will give it to the adult and left lateral segment we will give it to the child. So one cadaver can help for two people. So by doing this, so demands for the organ scarcity you can decrease. Sometimes donor healthy fellow, however, even it is less risky, but safety will be, the donor will be safeguarded. So total number one fellow giving to the two. So these are also two types. Usually in situ splitting, ex vivo splitting. That means if it is in-house brain dead donor is there, same hospital brain dead donor is there, family members agreed very early before landing into the hemodynamical unstable. So stable, no inotrope, family member added, donor is very young fellow, such patients we can split like a regular transplant. Like living donor surgery we do now, like the splitting, we do same thing in a cadaver also. We split it so that with the perfusion, blood flow, everything we can split it so that less cold ischemia. So sometimes patient is unstable, we need to remove the liver, and during the benching in the back table, you can split, that called ex vivo, out of the body. So you can do both ways. So by doing this way, you can do. This is a, because I worked for a living donor liver transplant, because after training from the Pittsburgh, they are predominantly cadaver program. When I come to the India, the problem is Indian donations were very least. So we, on 2 years, 3 years, we are ideal, useless fellows like that. We used to think. So that time we realized that living donor is the only option in India till the public get awareness about organ donation. So we went to the Korea during that time. They were the world leaders of living donor liver transplant. So there also cadaver donation is very rare. So once in a while they get a cadaver, they split it like this. So this is the one of the photograph album from my professor S.G. Lee. So these two are liver transplant recipients. See, this old man is right lobe he took, and this child took a left lateral segment. So one cadaver helped these two recipients of chronic liver disease. So that is the way cadaver program also can match to the pediatric, even though donor scarcity of the pediatricians. So one another, see, because more patients pool are there, but organs is still shortage is there in India. When World Liver Day, we search the WHO statistics. Average in India, 2 lakh patients are dying because of various liver disease, which include liver cancer also. In that, both north to south, east to west, government and private sector, all centers also doing a maximum of 1200 to 1500 transplant only. In that, super rich fellows, multimillionaire fellows are also dying because there is no organ availability. Either family members blood group not matching, or sometimes family members doesn't want to donate the organs. So various regions. So they depends on only organ donations. So they're all dying. So this much deficiency is there. So same thing is happening in other centers. Why can't we innovate other techniques like split liver, like brain donation or cadaver donation after circulator death, ex vivo organox usage. One more step. This is called domino liver transplant. That means a patient who is listed for a cadaver transplantation, but his liver, generally what we do in a liver transplant versus kidney transplant, all should know is, in a kidney transplant, we don't remove diseased kidney. We transplant third kidney in the iliac fossa. Whereas in a liver transplant, you have to remove the damaged liver because that is the seat of portal hypertension, that is the seat of GI bleed, that is the seat of ascites. So you need to remove the cirrhotic liver, then you implant the new liver. So these fellows listed for a cadaver transplant, one fellow, assume we remove his diseased liver and throw away. right? And we take a cadaver liver and implant. Whereas some condition, as you know, only in pediatric population, like genetic diseases or inborn errors of metabolism. I told you previously also, they doesn't have abnormality or liver problems, only one enzyme deficiency, like amyloid polyneuropathy, familial adenomatous amyloid polyneuropathy, FAP, or maple syrup disease. These type of patients, liver is normal, but extra liver they had some problems like amyloid dystrophy, all these things. So one of the fab fellow, liver was removed, and he got a new cadaver liver. Instead of wasting this liver, we are used for a terminal HCC patients, liver cancer patients, adult liver cancer patients, or chronic rejected liver waiting for the liver but is not getting, is succumbing. Such patients, marginal recipient, you can use that way. Even if you use a familial amyloid polyneuropathy liver, they survive 15 years. HCC patient living 15 years is a good life. So that is way we call as a domino liver transplantation. So they are using some ways. So, what is auxiliary liver transplantation? I just because many of the people not encouraging liver transplantation in a fulminant hepatic liver failure is this reason only. Because I have interviewed many of the hepatologists, pediatricians, intensivists. They say that, "Hey, you will avoid lifelong immunosuppression now. Why you want to?" By thinking that means they are missing 20% of the patients. They are dying, making it into irreversible step. So people have started, can we do anything avoiding immunosuppression long run? So what is that means? Auxiliary liver transplant means, as you know, acute fulminant liver failure sometimes reversible. Sometimes in even 80% it is reversible. So what we do is, instead of removing entire liver in fulminant hepatic liver failure, we remove a portion of the liver. So a native liver will be there in right side, and we add another graft from the parent or family member. Over a period of time, what will happen is, what is the fundamental principle? Watch closely. Initial period, liver failure, crisis tide over. So you give a immunosuppression so that the graft which is transplanted from the parent or family member will grow, will give a support till he recovers from the liver failure. Over a period of times, 2 years, 3 years, baby is doing well. You think that you just wean off the immunosuppression, stop the immunosuppressions. So his native liver will anyway work. This transplanted liver will get atrophy because of chronic rejections. You have stopped immunosuppression. And baby will, as you know, liver will regenerate. That is the principle of beauty of the liver. So your crisis is tied over, acute fulminant hepatic failure, and you have avoided long-term immunosuppressions by not doing a total liver replacement. You have kept a portion of his own liver, which you allowed to recover till such time your transplanted liver supported. So that means auxiliary, additional liver transplant. So this is the way of treating a pediatric acute liver failure patients. It cannot be done in adults because it's difficult, whereas in pediatric regeneration is very high. So in pediatric acute liver failure patients, auxiliary liver transplantation, we call as a surgical gene therapy. So you are assisting a liver to recover. So this is the one way. This is the one case we used to adapt in the US, but not yet started in India. As you know, children with malrotation, volvulus of the midgut coming into the late, full gangrene, resection, no bowel, small bowel, short gut syndrome. If they survive, you kept on TPN. Prolonged TPN causes cholestasis and liver failure. So such patient, if at all survives, they need both liver transplantation and small bowel transplantation, like combined. So this is the one way. So just 5 minutes. So this is recently I did a transplantation for Alagili syndrome. This is the baby, came with the 17 bilirubin. So we did a ultrasound, MRCP, both intrahepatic ducts, extrahepatic bile ducts were normal. So biopsy was done, absence of intrahepatic bile ducts, and patient also developed decompensation in the form of ascites and coagulopathy. And while evaluating with the cardiac, we found that patient also had a pulmonary arterial hypertension. That is one of the cardiac defects. VSD, ASD, our patient had a pulmonary arterial hypertension. That is a moderate. So gradient is not much. So we went on. And we also had some skeletal abnormalities in the form of high arch palate, butterfly vertebra is there. So we did a transplant. Actually, this patient was very poor, fruit vendor, old city. So we raised the funds by social media, and we did a transplant recently. So this is a first transplant in Pratima, where this baby also we did as a charity base. So biliary atresia post Kasai failure. So father donated. So this PFIC. This is we are doing a research project on PFIC, both transplant, non-transplant surgeries. So in Usmania, after doing a PFIC, this PFIC fully decompensated, liver cirrhotic, so we did a transplant. But these two brothers from same family members, both had a PFIC, referred for a liver transplant to Usmania. But when we critically assessed, liver function was still holding. Only itching, some amount of jaundice was there. So we did a ileal exclusion. I told you make them more bile salts, not reabsorb. So we did a ileal exclusion procedure. So now at present, both relieved of itching and good quality of life. So we are proceeding further. So some cases, if you detect PFIC early, I already told PFIC nothing but it is a bile salt export protein defective, that membrane. Otherwise, ductal system is normal, both intrahepatic bile ducts and extrahepatic bile. But they present like obstructive jaundice. So cholestatic jaundice features will. So only diagnosis by gamma glutamyl transferase GGT will be normal or low. That is, in that also variants are there, PFIC1, PFIC2, 3. That is a different types expression. They will have associated pancreatitis, cardiac. That way we classify like that. So this is doing a transplant in a less weight baby is very, very challenging. The reasons is, one thing is you need to have a more surgical refinement, reducing the size graft, preventing the bile leaks, and toleration also, because pediatrician more. Adult child will tolerate stress of surgery versus smallest baby. Less weight baby will more prone for infections, hypothermia, so many things are there. So, and most important thing is small babies will have a 1 millimeter. That means size of the hair artery. So to reconstruct, you need to use a microscope or magnifying surgical loops. So we did it one case as a challenging 4.5 kg baby. So this, I told I use a magnifying loops like that. So this baby also had a portal vein hypoplasia. Biliary atresia usually sometimes associated with a portal vein also underdevelopment. Such patients, you need to reconstruct the portal vein. So we used a PTFE graft. So we did almost 8 cases with the PTFE graft. I presented in a World Forum, International Liver Transplant Society of India. World Congress also I presented this. So many ways to reconstruct the portal vein. This is the one method. So hepatoblastoma, I already told all patients we don't recommend for a transplant. Even big tumor, but highly sensitive to chemo. After giving a good chemo, it is reduced. So we did a resection therapy and follow-up. Baby is doing very well like that. But one patient, sometimes after giving a full chemo, especially stage 4 or pretext 3, where after giving chemo still it is confined, so we removed the liver with IVC also involvement, inferior vena cava. So this baby we did a transplant like this. So HCC also, as you know, in children also hepatocellular carcinoma is very common in some of the conditions like glycogen storage disease, tyrosinemia, PFIC. These are more prone for malignancy. Some HCC patients, usually in adults, we use a criteria called Milan's criteria, UCSF criteria. But in general principle, you remember is disease confined to the liver, no extrahepatic spread, no vascular involvement. Usually such patients are indication for a transplantation. So once extrahepatic, there is no meaning of doing only transplant because already disease existing in other sites. So this is the one way. So I'm telling only positive things because, as you know, in a transplant, it's a complex procedure which is involves amount of risk complications. In pediatric liver transplantation, hepatic artery thrombosis is almost 11 to 20%. Hepatic artery thrombosis, if you don't treat revise artery within 6 hours, invariably baby will die because artery is a very crucial in a transplanted liver. And portal vein thrombosis also will be there, more so in a biliary atresia patient, congenital hepatic fibrosis patient. And in addition, biliary complications are more common in a living donor transplant because you are using a segmental, not using a major ducts, right branch, left branch. More so, if you do reduced sizing graft, you are cutting the liver all sides, bile leak can occur. So biliary complications. And sometimes hepatic veins outflow obstruction. Graft may twist because you are not anchoring. So these are the surgical complications. Medically, as you know, any transplant, either rejection or infections, both are in separate directions. In infection, you need to decrease the immunosuppression, whereas in rejection, you need to increase. But both will present in early week, early allograft dysfunction, we call as a, both will present rising jaundice, rising liver enzymes, both will have a mild degree of fever. To differentiate early stage rejection versus infection is very, very difficult. We thought CRP levels, we thought procalcitonin, but in a transplant, we have seen and enough number of articles also published, procalcitonin cannot give a clear assessment like non-transplant patient. Non-transplant patient, you may follow with the serial procalcitonin levels or serial CRP level. You escalate antibiotics, or if there is abscess, you drain or obstruction, you relieve it. Whereas in a transplant, it's not like that. It's very difficult. So sometimes we don't give a chance. If too late, patient will die in a sepsis. If you too late, rejection will occur. So we do a liver biopsy and confirm it proceeds. So sometimes heart issues will occur. We have seen after reperfusion, ischemic products will release into systemic circulation, causes cardiac toxicity. So this is one slide. If at all, because immunization is important aspect in a pediatric life, so all live vaccination, if at all wants to give it before transplant only. During the waiting or evaluation phase only give it, because you can't give any live vaccine after transplantation. Attenuated vaccine like polio, you know, oral polio is live vaccine, injectable polio is attenuated or antigen derived. Such you need to select alternatives. So that way we. But during that time, still he was active. He was a critic. He goes for the country audit of mortality and morbidity program for entire USA in a liver transplant. He will show that where you have done, and he always encourages.
Very simplified manner. He explained it beautifully. Every point is very catching. Thank you, Marson. What I feel, one side, he's from Alir. Just I inquired. It is the son of the soil of Alir. It's a Telangana Matti Bidda. He has got vast subject. At the same time, in our India, because so many cases are delayed, so many things are before presentation, because the basic problem is one side is the high tech knowledge is increasing, at the same time in our country, in our state, all unnecessary things in the name of treatment, the quacks, so many, especially the liver diseases, because of the pasarlu. First what they do, that is the problem. Why they are coming the late presentation, because of పసర్ వైద్యం. జాండీస్ అనగానే పసర్లు. మన ఎంజిఎం ఉంది, మన ఎంజిఎం ఎదురుగా కాకతీయ టాకీస్ ఉన్నది, అక్కడ పసరు పోస్తారు. సో దిస్ ఈస్ ద ప్రాబ్లం ఇన్ అవర్ ఇండియా. ఒకవైపు అంటే ట్రాన్స్ప్లాంటేషన్ హైటెక్ ఇంటర్నేషనల్ లెవెల్ thing is going on, but at the same time, next door, so many unnecessary things are going on. So how to reduce, how to stop. Tomorrow we are going to have a topic in our IMA, state IMA, the day-long anti-quackery discussion. The first time in the state IMA we are going to have tomorrow. So this is the comment. Thank you. Thank you very much.
The Epstein-Barr virus, as general pediatrician, I not rarely, but I see cases post-transplant. What is the link between EBV? When I should rush a patient to you, when I can keep to myself? Second, one more question. The theatre of Usmania Gandhi, you have done there, and a theatre in Pratima and maybe another hospital. Whether EB virus infection increases theatre-wise. Sorry for this question.
Yeah. So for generally any patient, when we are planning for a organ transplantation, first thing we make is recipient evaluation and donor evaluation. In that, we critically evaluate for all viral infection. Our protocol is recipient. If you take, we don't go by just HBsAg or anti-HCV. We do a PCR assessment. Even though HBsAg negative, HCV negative, still we make HBV DNA quantitative, HCV RNA quantitative. Like that, CMV, both IgM and IgG titer, like EBV, IgM, IgG titer, HSV, IgM and IgV titer. These we mandatorily do. In case patient is having a IgM titer is high, we do a quantitative PCR assess. Both in donor also, sir, we do EBV and CMV. But unfortunately, in our country, majority are IgG positive because they got infection but they are not sterile. So recipient also will be IgG. So in that with no issues at all. Whereas recipient is both negative for IgM and IgG, especially for EBV or HSV. Such patients we start prophylactic therapy. Like if it is CMV positive, we start valganciclovir. Like EBV positive, we start ganciclovir, like that. So definitely EBV virus, if you bypassing all these measures, after 5 years they are prone for that. Such situations, we follow them very closely. Unexplained patient fevers or graft dysfunction. Then we do a routine investigations like CVP, all these things. Still, lymphocyte or monocytes counts are more high, alarming, which is not explained by regular diseases. Then we send from, without any hesitation, we do a PCR assay. Now it is in Hyderabad also, we have a quantitative assessment of viral is there. Based on that, we treat aggressively. Otherwise, we decrease immunosuppression. They are prone for a lymphoproliferative disorders. So that is why we need to closely watch. After 2 years, 3 years, 5 years, any organ transplant fellows not doing well means we critically evaluate for EBV. Sir. I think majority of our all peoples came from government institutions. Even though we had so many issues in the government sector, I doesn't want to go into the politics as everybody is aware. But one problem which makes us to do in government sector is, so child will come. Small child may not speak. 6 years, 8 years child will come to our OPD. Sir, my father is a just Gurkha or security guard. My father is agriculture. I am not having any addictions. I born with genetic diseases. You tell me, or you refer me to the where one center where it is done a free of cost. In combined Telugu states, there is no referral center for liver transplant in government sector. That forced us to do at least, okay, infections, we try to do something. Even the government not providing a full and poor standard of class A operation theaters, clean hygiene, but still we tried, sir. Anyway, you know that that patient without transplant going to die. So we started that motto because that touches our heart. See, sir, we all came from poor background. One day we reached this stage means somewhere some help came from government institutions, government medical college, government junior college. So
I thought helping some way. So to start liver transplant, I took so much of pain. So you won't understand. That time in what you call this Arogyasri scheme, any diseases not more than 2 lakhs was the package, except cochlear implant. Even heart, everything is 2 lakhs was the maximum limit. Whereas we calculated the consumables, similar, it's coming around 10 lakhs. How to convince? So we went on to the minister, secretary 2000 times, any times. Hey, what man, you won't treat a regular disease, you are thinking a liver transplant. So one day what's happened is these rich fellows wants organs. I told you, no, sir, CEOs, all politicians, the children wants organ, their family wants organ. So they conducted a brain dead donation awareness program. They made a meeting with all government doctors, all these things. That day, I raised my voice. Sir, okay, Usmania people, Gandhi people, Kakatiya people declare the brain dead. So we are the organ suppliers, or any way our patients get benefited. Then one of the corporate fellows laughed. Hey, what man, you are putting a ladder into the sky? Huh? You won't treat. So then that day, I went on adamant. You give me the thought, at least government patient will benefited. At least out of 10, one organ will come to that. So you make it government way. So by doing all these 6 months, 8 months, 10 months, one day, that time Dr. Lakshma Reddy was there. He was some cordially he agreed. So he presented in a Telangana cabinet meet. In that cabinet meet, suddenly they called me in the 6 p.m., 7 p.m. that time. Do you have a documents which needs liver transplant, statistics, cost, everything? So I was going all 6 months, so I got a emails. So in that email I downloaded, I went, rushed to the secretariat. So they stopped me there. You give me the documents, wait for 1 hour. After 1 hour, Chief Minister somehow convinced, somehow not convinced. He says that we don't put it into Arogyasri at present. At least prove one case successfully, then we will give it to. So case base he sanctioned 10.5 lakhs. So pilot project. So after 2 months of that, then we got this. I told that lady who was from US gastroenterologist who was the NRI. So mother was intracerebral bleed, CVA attack and brain dead. So we took a organ from there. During that transplant, I was only trained fellow. Rest of the people doesn't have it. Sisters, everybody. So we trained them. I sat with the patient for 7 days continuously, stepped with the bedside. Luckily, by thank to the God or whatever the well wishers, that went on successfully. After that, the politicians, everybody comes, it's a credit. So somewhere we are not criticizing anybody. So positive thinking way to help one of the poor fellow, not hundreds, at least some fellows will benefit. So we made just last week only World Liver Day. I called all patients. We did a liver transplant in Usmania. 17 we did it. 15 fellows came. So we have shown in that one of the fellow was 2015. I did it first transplant. This is 22. So almost 9 years. So the way we hope. So like Gandhigiri, try. One day hope that some fellow will bend. And so coming to your answer, sir, always the best of best center infections complication is less. So whereas infection is the main villain for a transplantation, any organ transplantation. So in that we are trying, sir. Honestly, we are trying. So Pratima Group, they have a medical college, so they got a passion. So when we started in Pratima, actually I was also practicing in Yashoda Sikindrabad, did a 270 transplant there. Because of financially they charge more, so I left that organization, then started along with my entire liver transplant critical care team, nurses, everybody came. So we were 25 people, sir. So care, there is no, I'm not supporting on any organism because myself should convince I'm going to do a good justice or not. That is why I ensured that team is there. Then I started. So at least going on smooth, hoping that it will continue.
Congratulations to Dr. Madhusudhan and Pratima Group. Very nice.
So you should try to diagnose. I think you told when dental pediatric will tell differentiate between biliary atresia and neonatal hepatitis. That is one. The IC most of the time the suspicion should be on the brain, not in the brain. As I was telling, for any diseases or do anything. So with that, I think that's the only message I want to